All right, here we go. Here's another day of surgical smoke discussions, and today we're going to talk about the 2013 publication in the Journal of Urology, comparative safety analysis of surgical smoke from transurethral resection of bladder tumors and transurethral resection of the prostate. Is that looking okay? It looks kind of crooked, but so the objective was to analyze the gas generated from the transurethral resection of the prostate, otherwise known as TURP, and the transurethral resection of the bladder, otherwise known as TURB, tumor. Surgical smoke has become an integral component of the atmosphere in the operating room since the electrocoagulation was first applied by Harvey Cushing in 1926. With the use of energy-based technologies, surgical smoke is generated when target cells are heated to the boiling point. This causes the membrane to rupture. Then scatter cellular contents into the irrigation solution, organ spaces, and the environment of the operating room. Okay. The surgical smoke is commonly composed of chemicals, blood, and tissue particles, viruses, and bacteria. Exposure to aerosols is considered harmful to the health of the operating personnel because it contains the cellular particles, deoxyribonucleic acid, DNA, constituents, toxic gases, mutagens, and carcinogens. The chemical compositions and aerodynamic sizes of particles vary significantly, depending on the type of procedure, personal technique, pathology of target tissue, type of energy imparted, power level used, and the scope of surgery, cutting, coagulation, or ablation. An electrosurgery creates the particles whose size is less than 0.1 micrometers, and a laser tissue ablation does larger particles, 0.3 micrometers. But the largest particles are generated using ultrasonic scalpel, 0.35 to 6.5 micrometers. These particles travel up to 100 centimeters from their point of production. Short-term exposure to aerosols has been shown to cause eye irritation, nausea, vomiting, headache, sneezing, weakness, and lightheadedness, whereas long-term exposure causes cancer in animals and is also linked to higher incidence of cancer in humans. And electrosurgery is one of the most commonly used energy systems in the transurethral prostate and bladder surgery. During transurethral surgery, surgical smoke is generated when the target tissue is resected and vaporized. It has previously been shown that major chemical constituents include propylene, allene, isobutylene, 1,3-butadiene, vinyl acetylene, mecaptomethane, mecaptomethane, ethyl acetylene, diacetylene, 1-pentene, ethanol, piperylene, propinylacetylene, 1,4-pentadiene, cyclopentadiene, acrylonitrile, and butyrolactone, in the gas generated from the transurethral resection of the prostate, otherwise known as TURP. Of these three constituents, 1,3-butadiene, vinyl acetylene, and acrylonitrile, are known to be extremely toxic and carcinogenic. The irrigation solution contains 2.7% sorbitol and 0.54 mannitol. salt irrigation, and generates a lesser diverse type of gas at lower concentrations as compared with normal saline. It has been speculated that malignant tissue produces more toxic gases because of its nature and pathophysiology. To date, however, few studies have examined the chemical composition of surgical smoke generated from the TURP, or the transurethral resection of the bladder, TURB, which is the most effective surgical procedure in patients with bladder tumor. Given the above background, we conducted this study to analyze the gas generated from the TURP and the TURB. And the results, basically in TURP group, the mean age was 69.1 plus or minus 6.5 years, and the mean volume of the prostate and transitional zones were 45.5 milliliters and 24.1 milliliters respectively. But the mean prostate specific antigen level was 3.1 nanograms per milliliter. The mean international prostate symptom score and maximal flow rate were 21.7 and 12.7 milliliters per second respectively. In addition, the mean respected prostate volume was 19.2. In the TURB group, which is transurethral resection of the bladder, the mean age was 70 and the mean resected bladder tumor volume was 11.7 milliliters. The quantitative analysis of the sample with reference to the compounds registered in the National Institute of Standard and Technology database, we positively identified 16 compounds from group 1 and 39 compounds from group 2. So there's a table with different carcinogenic compounds, and I can't go through all these compounds, but I'll name a few. In group 1, propylene, allene, isobutylene, 1,3-butadiene, vinyl acetylene. And then in group 2, propylene, 1-chloro, 1,1-difluoroethane, pentafluoroethane, acetaldehyde, 1-pentene, perfluorocaprilic acid, caprylic aldehyde, and then ethanol, propanone, isopropyl alcohol, 2-methoxyethanol, hexane, cyclohexane, benzene, isopentanol, heptene. So human carcinogens include 1,3-butadiene, vinyl acetylene, ethyl acetylene, and acrylonitrile in group 1, and pentafluoroethane, acetaldehyde, benzene, toluene, ethylbenzene, and O-xylene in group 2. Moreover, animal carcinogens include 1,3-butadiene and ethanol in group 1, and pentafluoroethane, acetaldehyde, ethanol, hexane, and benzene in group 2. Furthermore, gases with carcinogenic potential yet to be classified as carcinogens by the International Agency for Research on Cancer include propylene and butyrolactone in group 1, and propylene acetone, isopropyl alcohol, N-heptane, and M-dimethylbenzene in the group 2. So they had a quantitative analysis of 39 constituents, and basically to prevent the inhalation of surgical smoke, a continuous irrigation and suction system during transurethral surgery is needed because surgical masks do not completely prevent smoke intake. Furthermore, a surgical smoke evacuation system or smoke filters, or both, should be developed and then made readily available to both operating room personnel and patients to ensure their safety during transurethral surgery. The results showed that various types of gases are generated during electrosurgery. Of these, human carcinogens, include 1,3-butadiene, phenylacetylene, ethylacetylene, acrylonitrile in the group 1, and then pentafluoroethane, acetaldehyde, benzene, toluene, ethylbenzene, and O-xylene in group 2. Extremely flammable gases were generated in group 1, and in the group 2, their carcinogenic potential is currently evaluated. A more diverse type of toxic gases was generated at higher levels from the transurethral resection of the bladder as compared with the transurethral resection of the prostate. It is well known that surgical smoke has cytotoxic, genotoxic, and mutagenic effects on both patients and operating room personnel. The toxicity of acrylonitrile is based on the formation of cyanide. It releases hydrogen cyanide in the presence of water. Its short-term exposure would cause eye irritation, nausea, vomiting, headache, sneezing, weakness, and lightheadedness. It has also been reported that its long-term exposure raises the incidence of cancer. Moreover, it has also been documented that its repeated and prolonged exposure to skin may irritate the skin and trigger the occurrence of dermatitis. Hydrogen cyanide is a more toxic substance. Once absorbed through the skin and lung, it may cause headache, weakness, throat irritation, vomiting, dyspnea, lacrimation, colic, and nervousness. Moreover, benzene irritates the eyes, nose, and respiratory tract, and can also cause headache, dizziness, and nausea. Its long-term exposure, even at low concentrations, may cause blood diseases such as anemia and leukemia. In the present study, we attempted to detect gases released during electrosurgery within a range of the molecular weight of 40 to 500 on GC per ms. But we did not include carbon monoxide and carbon dioxide, although they may be generated from the TURP and the TURB. Carbon monoxide is of particular concern because it is immediately absorbed from the peritoneum into the bloodstream, causing a route for systemic intoxication during laparoscopic procedure. Carbon monoxide binds to hemoglobin, thus forming carboxyhemoglobin and methamoglobin. This produces a hypoxic stress because of reduced oxygen carrying capacity of the blood in healthy individuals. Therefore, hypoxic stress can further impair cardiovascular function in patients with cardiovascular diseases. Once ablated, the tissue of 1 gram may have a mutagenic effect whose intensity is equivalent to that of 3 to 6 cigarettes during laser-assisted and electrocautery, respectively. It has been earlier demonstrated that electrosurgical smoke produces a helium environment that reduces the clonogenicity of MCF7, human breast carcinoma cells, in a dose-dependent manner. Another study showed that Salmonella TA98 strain undergoes alterations in histidine metabolism once it is exposed to smoke extract from human tissue ablation. It remains unclear whether surgical smoke would also have a mutagenic effect on humans, but this deserves further studies, as suggested by the cytogenetic data. And also, our results showed that 39 and 16 types of gases were generated from the TURB and TURP, respectively. There was difference in the type of gases between benign prostatic and malignant bladder tumor tissues. This indicates that electrosurgery of malignant tissue is possibly more hazardous to those who are involved in a surgical operation. Moreover, it is also noteworthy that the surgical smoke contains the viable malignant tumor cells which can be transmitted to others. To date, no studies have reported that the malignant tumor cells have been transmitted to humans. It is highly possible that aerolization of malignant cells is a potential threat to both operating room personnel and patients, and the operator in particular, who is the most closely exposed to the source of surgical smoke during transurethral surgery. Over the years, medical professionals have been more aware of the hazardousness of viral exposure after the initial identification of human immunodeficiency virus and HPV from the surgical smoke. This suggests that it would potentially cause viral infections. On tissue culture using a CO2 laser equipment, the proviral HIV virus DNA was retrieved from a suction tube that is routinely used to remove the plume. Another study reported that bovine HPV DNA was detected from the laser aerosol, indicating that there is a possibility that other harmful viruses might also be present in surgical smoke. The American Occupational Safety and Health Administration estimates that more than 500,000 workers are exposed to laser and electrosurgical smoke each year, including surgeons, nurses, anesthesiologists, and operating room personnel. The surgical mask only captures large particles that are greater than 5 micrometers, but does not provide adequate protection in filtering smoke. It has been reported that the incidence of nasopharyngeal lesions because of CO2 laser equipment was relatively higher in surgeons as compared with normal controls. This suggests that surgeons are at increased risk of developing nasopharyngeal lesions with the inhalation of laser plumes. In the present study, there was also variability in the type of tissue because of the difference in smoke composition between group 1 and group 2. The limitations of the present study are that we sampled the different types of tissue, that is the prostate tissue and the bladder, between the group 1 and group 2. Further, cadaver experiments are therefore warranted to identify the type of gases generated during electrosurgery of non-malignant tissue. In Korea, however, it is not easy to conduct a cadaver study, not only because it poses an ethical problem, but also both surgeries are done using urosol solution. In addition, we failed to use the standardized technique of smoke collection. Furthermore, the operation room setup was far from a controlled laboratory environment. These potential pitfalls may have skewed the results. In the quantitative evaluation of GCMS, some gases automatically enter. In addition, we failed to quantify other chemical gases when we should measure the concentration of such gases of carbon monoxide, CO2, O2, and nitrogen, for which we needed to have a set or higher baseline owing to their higher levels. Further studies based on other methods are therefore warranted to clarify the amount of gases and the safety limits for air concentration of each harmful composition. And that is my take today. It's in the Journal of Urology from 2013, and thank you for listening to me. Once again, it was the title was comparative safety analysis of surgical smoke from transurethral resection of the bladder tumors and transurethral resection of the prostate. Thank you.